Oh no, pleasure is mine. Thanks for having me on here.
Of course. I'm hoping that Robert got the invite as well.
I don't see him here yet.
Randy, want to get started?
Yeah, hey Robert, how you doing?
Doing well, thank you.
Good afternoon, everyone. So it's 4 o'clock. Welcome to Tumor Talk. We're back again on a new day. It's Monday now. We've done this on Tuesday since before COVID, and to accommodate some scheduling shifts, we've moved to Mondays. And I can't think of a better talk to give on a Monday than discussion on meningiomas, just for alliteration purposes, anyway. So meningioma Mondays. We probably won't continue that much longer, but at least for today, we're good. This is a joint collaboration with the Journal of Neuro-Oncology and Lenox Hill Hospital. We've been running it now for a few weeks. We like to highlight the reasons, the rationale, the relevance of recent publications in the journal. This talk, and today our special guests, Jai Thacker and Robert Riesenberg, are award-winning abstracts on meningioma research. And this has been part of an ongoing series where we've been highlighting these abstracts and this research that have been submitted to the tumor section. So without further ado, I really do welcome you guys today. It's our privilege. Dr. Sheehan usually joins a couple minutes later, so he'll be here. Why don't we get started with Jai Thacker, since you're already up there. Introduce yourself, give us a little rundown of what you're doing, and we'll try to take a few questions after, and then we'll move over. Okay.
All right. Well, thanks so much, the entire team of Lenox Hill and Journal of Neuro-Oncology, for having us here. It's truly a pleasure. So I'm Jai Thacker. I am currently faculty at University of South Alabama, Mobile, up deep south here. And but this kind of research is more focused on what I did or learned in my fellowship with Dr. Kelly and Barkadarian up at Santa Monica. So I basically looking at the minimally invasive treatment options for especially an elderly population for meningiomas. And I'm going to talk about outcomes, readmissions, and tumor control from there. In the author, you see a bunch of authors, and all of them did a great job in helping me get this project ready to go. And we have a bunch of students, nurse practitioners, neuro-ophthalmologists, co-neurosurgeons, or ENT experts, and of course, Dr. Kelly. So, moving on, I have no disclosures for this talk. Goals of the study, it's, as much as we're going to talk about the surgical outcomes, the complications, the readmissions, the good and bad of, the skull-based meningiomas and regular meningiomas as well. It's important to kind of highlight what patients we did not operate on, what were the indications for surgery, especially in the elderly population, and then, talk about keyhole or minimally invasive approaches. Is it just cosmetic? Is it just smaller incisions? What exactly is, minimally invasive approaches? So moving on to the methods, we basically looked over 10 to 12 years of our database at Pacific Neuroscience Institute and at John Wayne Cancer Center, and did a retrospective analysis. All of the data was fed in a prospective database, and so it's essentially a retrospective analysis of a prospective database. Total about 291 patients met this criteria, median age of 60 years, and total of 323 operations, but we're going to focus on 118 elderly population patients over 65 years of age, which underwent 126 operations. About 20% of them were redo operations, and then 63% of our cohort was skull-based, and remaining were non-skull-based. Just to give a hint of, the areas which we call minimally invasive are especially the operations we did when you could do it to a traditional route, and we opted for a lesser, more precise focused craniotomy route, which includes an eyebrow approach or supraorbital on the left op, mini-terional remaining around close to superior temporal line, of course, endonasal for some meningiomas. Then a lot of times, for big paraphalcy meningiomas, especially near the Morse strip or eloquent cortex, you don't want to manipulate too much. So we came from the contralateral side and did it endoscopically or endoscope assisted as well for contralateral transphalcine approaches. And then the traditional workhorse of retrosec approaches with smaller incisions and using endoscopes for covering some blind spots, which we'll talk about later. So coming on, sorry, excuse me, I'm going to use some busy slides, but I'll walk you through them. This is a table. The first half of the table is essentially covering the patients with did not undergo surgery. So essentially, if you look at it, very few patients did have peritumor edema, but because of their age, some 90, 93, in 80s, we opted for conservative management, and most of them remained stable, except in this group, one patient had interval growth, and the patient chose to keep following it. He was an 81-year gentleman and essentially asymptomatic. Some skull-based tumors as well, intermittent diplopia, few, but out of all the 31 patients which we observed, one end up, having a substantial growth requiring stereotactic radiosurgery, and then subsequently has been tumor, the tumor growth has stopped since then, and it's been about 18 months or so. And as far as, patients we did operate on, what were the indications? Mainly, obviously easy ones are symptomatic, having some sort of weakness, some deficit, some drift, some seizure, but apart from that, maybe associated peritumor edema. Tumor has grown in size and you've watched it, in subsequent scans, or a combination of all these. There were 4 patients in which it was purely incidental and the patients just wanted it out, and it's patient's preference at that time, and we removed this the tumor. The mean age of the patients which were observed were a little higher than the operated ones. There was 78 as opposed to 72. And as expected, the maximal tumor diameter was obviously higher in operated 135 millimeters as opposed to 22, which was not significant. So just a rundown of like basic analysis of the 2 groups, non-elderly on the left, elderly on the right side. Not majorly anything was different, except as expected, the preoperative KPS score, was better in non-elderly group. But apart from that, everything was pretty similar. The approaches used for Keyhole specifically were endoscopic, endonasal, supraorbital, mini-terional, retromastoid, along with suboccipital, and then transphalcine approaches as well. The endoscope used during the surgery, roughly about 50%, 40 to 50% of the times we bring in an endoscope to see the anatomy better and maybe take more tumor out. And the gross and near resection in elderly was about 71%, and in non-elderly was 67%. Again, want to direct you to this row that says, there were a lot of tumors with invasion to Meckel's cave, cavernous sinus, or infratemporal fossa, and it's not possible to take the entire tumor out, at least in our experience. And then following up in median length of stay is 3 days for these challenging tumors in both cohorts, so no significant difference if you're elderly or not. Improved functional outcomes. Let me try to move this. Improved functional outcomes in about over 85% overall had improved or stable KPS score before they came in. Major complication was seen in about 8% of the cases overall, and readmission rates varied between 4 to 5%. No significant difference in elderly as opposed to non-elderly group. This is mainly for the elderly group for the complication rate. About 5 patients had a stroke after surgery. 3 of them recovered to baseline KPS, and then 2 had deficits, permanent deficits after surgery. Hematoma, 2 of them required reoperation. Worsening vision or cranial nerve deficits was seen in roughly about 3 to 4% of our cases. 0 wound infections, no meningitis, and no pseudomeningoceles or CSF leaks was noted. Importantly, I think when we talk about elderly, it's important to mention systemic complications. Except one aspiration pneumonia, we did not notice any DVT, PEs, or any cardiac events in our patient population.
So this is just the elderly cohort.
This
this
is
table.
just the elderly cohort, correct. And then the readmissions, fairly low, I would say 4%. Two of them were subdurals, which were managed conservatively. One, we felt like the decadron was being a little faster, and we put it back on. Patient improved some seromal collection, which was non-operative, and then transient neural decline, which improved after steroids as well. Stratifying these patients based on 5-year age group. So as expected, the ASS score and the comorbidities more than 3 or more increase as the age progressed. This is obviously expected, but despite this progression, if you look at the complication rate, the mean length of stay, the median was 3 all across, did not change much. Certainly the gross over resection rate or near total, which was more than 90%, but less than 100%, was I would say a little less in more than 80-year age group as well. As far as the tumor control is concerned, we had data for just over 100 patients, and noticed about 4% of the patients had recurrence despite gross over resection, and then of the patients who had residual, about 10% of them had the tumor progression. So overall, 15 patients with some sort of recurrence or progression, which required 3 of them required repeat surgery, and remaining were managed by mainly stereotactic radiosurgery with good control from there. So, we did publish this paper as well in the JNO Focus recent edition, but offshoot of our discussion, I think it's also, important to, we kind of like mentioned briefly about above or below, and if you're talking about minimally invasive, are we going to use an endoscope or a supraorbital craniotomy for a standard tuberculum cell? And this particular illustration, this is drawn by our illustrator, Joshua Emerson. This could go either way, to be honest. And then looking at more precise details about the cella, the shallow nature of the depth of the cella, the tuberculum angle, more tumor above the planum, and certainly plus minus, I would say optic canal invasion are kind of important factors. So if you go back, say this tumor does not have optic canal invasion, has a little bit of lateral extent along with a shallow cella, so pretty much very favorable for an eyebrow craniotomy, as opposed to say this tumor, which has an expanded tuberculum, so pretty steep tuberculum angle along with say optic canal invasion. In our series or protocol, we would probably favor going from below or using an endoscope. If you look at this, these are actually very favorable from either one. We decided to go from below just because of this coronal cut. Essentially, bilateral optic canal invasions in our hands was more amenable for endoscopic resection, in which you can nicely decompress the optic canal pretty extensively, and you can see the nice neo-septal flap enhancing there. And for anterior skull-based tumors, favor more obviously eyebrow approaches, just because you have a better olfaction preservation as coming from below. You disrupt the cribriform, and certainly better cosmetic outcomes. Bushy eyebrow is always helpful in having a better cosmetic appearance after an eyebrow. More importantly, I think it's important to recognize that when you make an eyebrow approach or mini terminals, you're obviously the exposure is very precise and focused, so you're limited by some working angles, and that's why you have these blind spots. And then there's a learning curve for that, and with experience you learn that the blind spots, where they are and how can they be eliminated. So I think in our series we use endoscope a lot, and something which I took from the fellowship as well, to use endoscopes a lot. So this is kind of an olfactory groove meningioma. You could see on the left is the microscopic view. This is the right side. You can see the falx. You can see the olfactory nerve, the right frontal lobe. Now you bring in the endoscope, you see this tumor very nicely being peeled off from the olfactory. You see some tumor which we buzz later on to get better, the tumor control, bipolar the dura, bipolar this attachment, and then you also see the left side very nicely. There's a little bit of tumor and bleeding left there, which we took out. And so this view is obviously very tough to to have a visualization with an eyebrow approach. Certainly, if you do a bicoronal approach, you can have a better approach with microscope. But eyebrows, good exposure, heal well, lesser chances of infection, and same exposure. So that's kind of like the concept of minimally invasive. Traditionally, this is also another clinoidal meningiomas. This is on the left, you see the eyebrow approach. On the asterisk, you see a little rind of tumor, maybe below the optic nerve. And, most of the people agree, like, the reason they used to do craniotomies a lot was because of this blind spot and to mobilize, the optic nerve veil, and obviously, free up this association with the internal carotid artery. And if you bring in the endoscope, you're pretty much seeing exactly what you would see, with the craniotomy being done. You can, you have a good view of the superior hypophyseals, diaphragm sella, tumor left underneath the optic nerve, what needs to be mobilized more, and you can use like your ring curettes and essentially minimally invasive instruments to take those tumor out. Similarly, in retrosigmoid approaches, this is on the left is a microscopic view, cranial nerve 9 or lower cranial nerves, and then 7-8 complex, and there's some tumor in between. But you see how the perspective changes when you introduce the endoscope. You know exactly where you could take the tumor out more safely, and defines their anatomy very nicely. And this is another view of a big paraphyseal meningioma, which we did a contralateral approach. So essentially a fox, and this is the other side, taking the tumor out from the other side. But as soon as you introduce endoscopes, you certainly start seeing the tumor interface on the opposite side. You know exactly, what needs to be taken out. It's very helpful to get that perspective with the endoscope when you're using this contralateral keyhole approaches or other approaches as well. One big thing is, if in big tuberculum cellular meningiomas, this is actually the image I showed before, was very calcified. When you're taking it out from like a conventional pterional or an eyebrow approach, a lot of times the stalk is kind of the blind spot and you don't know where the stalk is. It takes some time, and coming from below eliminates that. And you see a nice view of the stalk here after the tumor has been decompressed, posterior communicating artery. You can see superior hypophyseals. You can trace the pituitary gland all the way back and keep gently lifting up the tumor. So the stalk is very predictable. You can avoid a major catastrophe coming from below if, as the obviously the evolution happens in surgical techniques. So, overall, I think patient selection we talked about is very important. Obviously, these are benign tumors, especially in elderly, don't merit a complication. So obviously, if stuck to an artery, and if you can't get it all, it's better. We have good backup plan in terms of stereotactic radiosurgeries of different sorts. Certainly, the minimally invasive concept is more on brain and not just only skin. Skin for sure heals better, smaller incisions heal better, but not using retractors, using more endoscopes and making smaller, precise openings for the pathology needed, kind of like are important. Using endoscopes frequently, I think that is one of the biggest take-home messages for me, at least. And more it defines your anatomy well. You get a panoramic view of what you didn't imagine before with the microscopic view. And certainly application, I think it's important to recognize that it doesn't happen overnight. You need to do a lot of pterionals and regular approaches, traditional routes to understand the anatomy better, and then precisely can use that in your training. So I feel like I used slowly I'm using all these minimally invasive techniques in my practice. This is Barhol MVD I did for trigeminal neuralgia, patient discharge and postoperative too. You could use an eyebrow approach. This is one of the patients that had prior surgery before I came here and needed decompression of the brainstem cyst and some tumor debulking, which was easily achievable with an eyebrow as far as the exposure is concerned. Certainly some vascular, as much as you want to do, minimally invasive, but this was a ruptured P2 aneurysm with low dome to neck ratio and could not be coiled or stented. And we did a subtemporal, traditional old-fashioned subtemporal approach with a fenestrated clip going across the P2 aneurysm. Similarly, an MC aneurysm, very tempted. I kind of like almost lost out to do a pterional for 1 year in my fellowship. And then I had to go back to regular pterional in this one, since I was not sure what was the working angle of the clips for, to clip this MC aneurysm, and eventually needed 3 big clips staggering onto each other, which I think, in my given limited experience could not have happened with mini pterional, and as probably, you have a learning curve. So it's important to recognize that and, do the best you can. And similarly, another CP angle tumor we did last week, with good outcomes, patient discharge and postoperative did too. So that was our research, and happy to take any questions.
Thank you so much, Jack. Yeah, to be honest with you, I want to make sure that Robert gets enough time as well. We try to limit these to about 30 minutes so that people stay interested, to be honest with you. So we'll move right into Robert, and then if we have time at the end, we'll bounce back and we'll ask some questions for everyone. Robert, how you doing?
Doing well.
Yeah.
Thank you. Yeah, I gotta remember to unmute here.
Yeah, it's all right. Why don't you share your screen and get set up? You can introduce yourself before you start as well.
Yeah, so I'm Robert Riesenberg. I go by Bob, but I'm a fourth year med student at Northwestern, and my talk is primarily the clinical work of my research mentor, Dr. Block. And so, can you guys see everything? Okay.
Yep.
Entire screen. Okay. So. Yeah, so this is really a talk about an approach that is a modification on the supraorbital keyhole approach. It's cranial orbital craniotomy via an eyebrow incision for resection of anterior clinoid and tuberculum cella meningiomas. So here we see images of 4 patients with anterior clinoid or tuberculum cella meningiomas. These lesions commonly grow and compress the optic apparatus, resulting in visual deterioration, which is the most common presenting symptom. So the goal of surgery for these patients in general is decompression of the optic apparatus in order to preserve or restore as much visual function as possible. Historically, these have been approached with either pteronal or orbizogomatic approach. Transsphenoidal as well can be used, as we just talked about. More recently, the minimally invasive transeyebrow supraorbital keyhole approach, which involves a small craniotomy just above the orbital rim. So as we just talked about, this really is trying to reduce morbidity-related brain retraction. But you are limited in your viewing angles and in your intraoperative maneuverability. So I'm going to describe a modification that kind of tries to address some of those issues. So here we can see how the patient's positioned, and the eyebrow incision is planned just like a normal supraorbital craniotomy, head rotated 15 degrees to the contralateral side. Soft tissue is dissected, and the temporalis muscles incised and reflected away from the superior temporal line. Next step is the osteotomes taken, used to break the lateral orbital wall and the orbital roof through the McCarty burr hole that's been drilled here, thereby gaining access to both the the anterior cranial fossa and the orbital space simultaneously. So then the craniotomy is completed by taking a cut through the lateral orbital rim, and then the orbital rim more medially, just lateral to the supraorbital notch, and connecting the burr hole to the more medial cut with a craniotome. So here we can see that the bone piece can be removed as a single bone flap, allowing you to see the paraorbita and the dura here. The paraorbita and the dura then dissected away from the remaining orbital roof back to the level of the anterior clinoid process, and you can then remove the remainder of the orbital roof in a piecemeal fashion so that you have good visualization of the optic nerve as it enters and exits the optic canal. So the idea behind this is that it allows for good visualization of the optic nerve as you drill out the optic canal to decompress the optic nerve, which is one of the key steps in relieving tension on the optic nerve, relieving pressure on the optic nerve, and preserving and restoring visual function in the postoperative period. So following that, the drilling is continued down. We don't really have pictures of this, but the drilling can be continued down laterally to the optic strut, releasing the anterior clinoid process. So Dr. Block does do a extradural clinoidectomy. The dura is opened, and here you can see the optic nerve entering and exiting, where it enters and exits the dura. The meningioma is then debulked, and here we can see the final result where it's completely debulked and kind of free from the bony detachments. So now I'm going to talk about a case series of 6 patients operated on via this approach compared to traditional fronto-orbital craniotomy. They all received preoperative acuity and visual field testing. This table summarizes results of the case series. On the top, we have the cranio-orbital patients with the approach just described. The bottom, the traditional fronto-orbital patients. In terms of presenting symptoms, visual deterioration was the most common, followed by headaches. 2 patients presented incidentally. In terms of diameter and other tumor characteristics, the groups were similar. There was a high rate of optic canal invasion and cavernous sinus involvement in the 2 groups, with only these 2 patients in the cranio-orbital group not having either of these features. The dural attachments of the tumors were not coagulated in this area, so this kind of limited the ability to achieve a Simpson 1 or 2 resection. So only 1 patient in the cranio-orbital group achieved a gross total resection defined as a Simpson grade 1 or 2. But only 1 patient also had tumor recurrence in the follow-up period, and that patient was in the fronto-orbital group. That was asymptomatic, didn't require any intervention. In terms of visual outcomes, for patients with preoperative visual deterioration, 2 out of 4 patients in the cranio-orbital group improved in the postoperative period compared to 3 out of 3 patients in the fronto-orbital group. This difference wasn't statistically significant. These 2 patients up here, whose postoperative vision was stable and impaired, patient 1 had a long-standing tumor which had been previously resected and irradiated, and she presented with over a year of visual deterioration. Patient 2 had hypertension and diabetes, which had contributed to an ischemic optic neuropathy. So given their situation, a stable visual outcome was considered pretty good for these patients. Nobody had a postoperative visual worsening. In terms of complications, the cranio-orbital group, 1 patient had a new superior scotoma in the contralateral side, but on the left side, she had presented with near complete loss of vision, which was almost completely preserved postoperatively. So she still had a good visual outcome. And in terms of the fronto-orbital group, 3 out of the 4 patients had complications related to soft tissue dissection, so numbness, pain, and a frontalis palsy. And this difference between the 2 groups with regards to the soft tissue dissection complications was statistically significant. So in order to also assess how minimally invasive approaches compared to transcranial and transsphenoidal approaches reported in the literature over the past 10 years, we did a literature review using these search terms, and we compared visual outcomes and complications in these groups of patients. We found that amongst patients with preoperative visual deficits, patients operated via transsphenoidal approach actually were about 1.5 times more likely to experience postoperative visual improvement compared to transcranial and the supraorbital keyhole patients. This may be related to selection for these patients. So I couldn't do statistical tests on these because we only had averages reported in a lot of the papers, but the tumor size was smaller in the transsphenoidal group on average. And tumor size has been reported as an important prognostic factor for determining visual outcome following surgery. So selection probably played a role in the difference in outcomes. And then in terms of complications, CSF leak and meningitis were significantly more complicated, or I'm sorry, significantly more likely in the transsphenoidal patients relative to the transcranial and supraorbital keyhole patients. And stroke and neurologic deficits or vascular injury and hematoma were significantly less likely in the transsphenoidal patients compared to the transcranial and keyhole patients. So in summary, we describe a minimally invasive transeyebrow cranio-orbital craniotomy, which attempts to address some of the shortcomings or difficulties of the supraorbital keyhole approach with the addition of orbital rim and roof removal. And we demonstrate the safety and efficacy of this approach through comparison of this approach to a traditional frontal orbital approach, where we found similar visual outcomes and decreased complications related to soft tissue dissection in our case series. And also in our literature review, we found that transorbital approaches are applied in a more limited population of patients maybe, but have improved visual outcomes for these patients, probably potentially partially related to the initial tumor characteristics, but also higher rates of CSF leak and meningitis. So I'd like to thank my mentor, Dr. Block, and Dennis, John, and Aiden, who helped me with this project.
Great job, man. Thanks a lot, Bob. So, we're limited on time here. Like I said, I like to cut it short. I guess, the one thing that I gather from both of you, it's actually great that you guys both presented, because I think it's, very, very interrelated here. But regarding, these procedures, I feel that what you're showing is that the smaller, more minimally invasive approach, regardless of age, really, is not just a better recovery time for patients, but you're getting not just equivocal, outcomes, but it may be sometimes even better. Is that what you're finding in your standard practice? I mean, is there any time now? I mean, Jai, you pointed this out. There are still times to do the bigger craniotomies, but is that the sentiment that I think I'm getting out of this?
Yes, the answer to that is yes, for sure. I think there's certainly a learning curve, and it's more to do with, like, once you're past that learning curve, in terms of I think the first hurdle is to understand the concept that it's just not smaller incisions. It's more to do with, like, how are you basically handling the brain.
Mm-hmm.
I don't know how many times I got recognized during my fellowship that be gentle, releasing CSF, cistern relaxation, no need of brain retractors, and then the heal well because it's a smaller opening. I feel like that's the first part to understand. Like, first is brain handling, then knowing the anatomy. If you've done enough of, like, the regular, as you go through residency and you do enough of, like, regular terional or middle fossas or petrosals, then you kind of know what needs a bigger operation and what does not. And then I think the major shift, which has happened is the goal of the surgery. I think this may be controversial, but a lot of times now we leave the tumor behind, and it's okay. I think that's just my training, and I may be wrong completely, and some people may not agree with that, but I feel I've learned that it's completely okay to leave benign tumors behind, and give the patient the best quality of life. And if they recur, the data suggests great outcomes for radiation. And so that's, I think, the goal of surgery also matters. In addition, one last point is, I think I didn't mention my talk, is TIVA protocol, which I learned that we use a lot in my fellowship, and I've started using in my practice here. Is total IV anesthesia. And I think the post-operative cognition is much better. Delirium is much less nausea, vomiting, lesser chance of complication, and patients are up and about very fast.
So you're doing TIVA on all of these cases?
All of these cases. Correct.
Are you doing it on big terionals as well, or just on the minimally invasive boutique stuff?
So, big terionals, say, for example, the MCA aneurysm, which we clipped, I had a patient was monitored, so they had to use TIVA regardless.
They had to, no matter what, yeah.
Right. And so, but, it's a bad day if you don't use TIVA anymore. And I feel like the patients are waking up just much better, as opposed to gas and, all that stuff.
Yeah, absolutely. Absolutely. I got to tell you, I mean, I'm very impressed with both of you. I want to thank you both for being a part of this. It's been a great session. And so we hope to have you guys back. Obviously, Jai, your paper came out, but Bob, let us know when your paper comes out, and keep us in mind for future papers as well. And we'll get you guys back on here. This will be posted, just so you guys know, on the YouTube site for the JNO. It's been streaming live on Instagram and YouTube right now as well. So you can feel free to share this along to colleagues and students interested. And good luck to both of you. We look forward to having you back.
Well, thanks so much for this opportunity. Appreciate it.
Yes,
absolutely.
Thanks, guys. Thank you.
Take care, guys. Bye-bye.
Sure.